Okay, good morning, everybody. Why don't we get started? It's Friday, February 14th, Valentine's Day, and we couldn't think of a better presenter today than someone that I have long admired, who's a real um, great addition to the Department of Ophthalmology. We've got Dr. Michael Nguyen, who graduated as a chief resident in our program a couple of years ago, and he subsequently went down to Boston to complete a pediatric ophthalmology fellowship at Harvard, and he was recruited back to the University of Toronto, and he's on faculty with our department and on staff at Sick Kids, Humber River, and the Kensington Eye Institute. I have the great pleasure of working alongside him on Thursdays, and I'd like to welcome Michael to his first grand rounds as a faculty member. So Michael, the floor is yours, and I'd like to thank Manlong and Anna for being our resident presenters this morning.
That's great. Thanks, Amadip. Good morning, everyone. Really great to be back here, and thanks so much for having me present our grand rounds today. I'm joined by Manlong and Anna, two of our PGY3 superstar residents who I recently worked with at their Sick Kids rotation. These two cases that we are presenting today are actually patients that I took care of during my fellowship in Boston last year. I do recognize that a lot of people on this call are not pediatric ophthalmologists or strabismus surgeons, so we did try to make these cases also interesting for the comprehensive ophthalmologists as well. And if you do perform strabismus surgery, that's awesome. And I would love to hear your thoughts on these cases. And of course, happy Valentine's Day, everyone. I'll hand it over to Manlong so she can start sharing her screen. And the first case that we have is titled Eye Crossed to Star-Crossed Lovers. It took me a while to come up with a clever pun for all my cases. So that's the one I got for this one.
Good morning. Can you hear me well? And can everyone see the slides?
Yes.
Okay. Good morning, everyone. I'm Manglong Shi, PGY3 ophthalmology resident at UOFT. Many thanks to Michael for the opportunity to present the case here. The talk is on from eye crossed to star-crossed lovers. Here are the objectives. First, to review surgical considerations for chronic large-angle esotropia from cranial nerve 6 palsies. Second, to review indications for strabismus surgery in monocular patients. And finally, to review concepts for anterior segment ischemia and the psychosocial impact of strabismus surgery. Case 1, we have a 57-year-old man present for evaluation of large angle esotropia and head turn. As we can see on the image here, the patient has a really big left head turn and significant esotropia in both eyes. History of present illness. In 2016, he had a motorcycle accident in India after hitting an animal. He was treated at a local eye hospital, but unfortunately was left with a blind right eye and traumatic complete bilateral cranial nerve 6 palsies. Eyes are now severely adduct. Large left head turn to see with his good eye, the left eye. He reported that he has very sore neck. On history, he had bilateral traumatic cranial nerve 6 palsies and the right eye with a vision of no light perception with retinal detachment and glaucoma with some kind of stent placed in the past. The left eye, he has glaucoma. In terms of past medical history, he has hypertension and he was on Ramipil orally. He was also taking dorzolamide timolol eye drops in both eyes for his glaucoma. He does not have any allergies and no family history of strabismus. He washes dishes in a restaurant. At initial exam, the right eye has no light perception vision with a non-reactive pupil and an IOP of 20. The left eye has excellent vision at 20/20. The pupil was round, reactive to light, and the IOP was 15. On slit lamp exam, as we can see on the photo on the top left, the right eye has 0.5 conch injection with no visualized hardware or trabeculectomy. The cornea has a central opacity, and the eye has a shallow AC, with iris synechia to lens and iris cornea touch 360, as well as a wide cataract. In the left eye, the anterior segment exam was really unremarkable, except for a mild cataract. Dilated fundus exam has no view to the fundus in the right eye. Serial B scan showed total retinal detachment. The left eye, the disc was pink and flat, with a cup-disc ratio of 0.7. The macula, the blood vessels, and the peripheral retina are unremarkable. Here are the sensory motor exam. Can we have someone from the audience to describe what they see? Sandra, could you unmute the audience?
Maybe we'll take a PGY 3 or 4 resident.
Go ahead, Waleed.
Okay, so so this is a 9 by this shows esotropia and primary gaze, along with the limitation of abduction in the left gaze of the left eye, and also there's a limitation of abduction in the right eye as well, and right gaze. In terms of elevation, is also limited in both eyes, and also on like in the lower gaze, the eyes also look esotropic, and in the upper gaze, the eyes are also
That's great. Thanks, Waleed. Yeah, so this is a bit unfair, you know, this type of 3x3. It's not typical, but I think it's important to be able to have an approach to present, for example, for the Royal College. So whenever there's a 3x3, and there almost always will be a 3x3 for every oral examination. I remember Dr. Kraft, who is operating today and can't be here for grand rounds, but I remember him teaching me that, you know, a good way to approach these, as you did, Waleed, was to start with the primary picture in the center. You know, this patient has a very large esotropia in center gaze. Then you can move left and right, and you see that, you know, there's still severe abduction in both eyes. In fact, both eyes are probably positioned at around like a -6 on the right eye and a -7 in the left eye. We know that, you know, 0 is full abduction, -4 gets you to about midline. So if someone can't abduct past midline, we would call that -4. If they're not able to even get to midline, that's when you start getting to these weirder numbers like -5, -6, and -7. This picture, you know, this 3x3 is almost kind of like we took one photo and we kind of just copy and pasted it 9 times, which is just again to show how severe this patient's bilateral complete cranial nerve 6 palsy is. Whenever we have a sensory motor exam, also important to kind of look at the other components of it. We always focus on the 3x3, but we also want to look at the other measurements that we either perform or the orthoptist is gratefully doing for us. We notice that there is a large left head turn. We notice that we measure it to about 40 degrees. If you didn't know, we can actually measure this using this interesting instrument in our clinic. And 40 degrees is very significant. So if you look at the patient in the top right, this is how he looks at you in clinic. So this is how he walks around day to day. And the reason why he's doing that is because his left eye is the 20/20 eye, right eye is the NLP eye. So he's only able to fixate with his left eye. And for him to do so, he has to turn his head to the left in order for him to fixate at you. Of course, the stereo vision is going to be negative. That's put in there, you know, just for completeness sake. But if someone has this large deviation, it would not be typical to expect someone to have binocularity, of course. And something else that we could also comment on is the alignment. This is something that was quite interesting, but because this patient's, you know, deviation is so large, we actually wrote the alignment in degrees. And if you think about it for a second, that's a bit unusual because when we are in clinic, we have prism bars, right? So we have, you know, prism bars, we have loose lens prisms, and these are measured in prism diopters. But we typically don't have protractors, and we're not, you know, using weird geometry and trigonometry to measure the patient's deviation in degrees. Perhaps it's easier for a patient to understand in degrees, but, you know, we measure in prism diopters. And to understand why we had to write 90 degrees in this situation, we would probably have to go to the next slide so that we can take a quick break from, you know, our case to talk about the OCAP, which is coming up for all the residents next month. So I'm going to do a quick optics break to help you guys hopefully get a few more questions correct because optics is a substantial subsection of the OCAP. Next slide, please.
Hi, Michael. Dr. Slomovic raised his hand.
Oh,
Uh,
sure.
I know your unexpected question from a cornea person. What would happen? What would he complain with, and how would he present if he was able to see from the other eye?
That's a great question. I think it would depend on which eye has better vision. I guess if he was 20/20, he would probably still favor one eye and he would still present with a head turn. It would either be, 40 degrees to the left or 30 degrees to the right, whatever that may be. But he would still have a substantial head turn because otherwise he wouldn't be able to fixate because of how adducted the eye is.
Would he alternate head turns, and would that decrease his complaint of pain in the neck?
He could be alternating, but he would then just have pain on both sides of his neck because like you can imagine like this
Yeah.
hurts my neck just holding it for 5 seconds. And I'm trying to imagine having to walk around my entire day being like this or even just alternating. I feel like both sides of my neck would just hurt.
Thank you.
Next slide, please. So for optics and the OCAP, one very important concept is the prism diopter. And this is just to remind us about what that unit is for when we're using the loose lens prisms. So a prism diopter is defined as displacement of light of light at 100 centimeters or 1 meter by 1 centimeter. So pictorially, if we have a prism diopter triangle that is represented by a 1 prism diopter prism, and we have light that enters from left to right, it hits the prism, and then it's going to bend towards the base. So we have, prism diopters bends towards the base. We remember that with the 2 Bs. And at a distance of 100 centimeters away from the prism diopter, then the light is displaced by 1 centimeter. So this is the definition of a prism diopter, a very strange unit that is, defined in centimeters. Very unusual, but this is something that is very important. Also note that this has nothing to do with diopters as well, which is another difficult topic for residents, but completely unrelated to the unit of diopter. So just remember this, and this is very important. So maybe we can try some questions with the residents. Oh, sorry, before I went on to that, we also know that the relationship between degrees and prism diopters. So you remember that for our patient, we had to write degrees, and we'll get to that in a second. But in general, when we have 1 degree, that's pretty much equal to 2 prism diopters for angles that are less than 100 prism diopters. And we'll also explain why this is. If you have trouble remembering this relationship, just remember that degree has 1 word and prism diopters has 2 words. So 1 degree is roughly equal to 2 prism diopters. This is also useful to explain to patients, with smaller angles. If someone has an ET of 30 prism diopters, then you can tell them that, your eyes are, crossed about 15 degrees. And this is something that patients can understand because, we have trouble understanding prism diopters as ophthalmologists, but patients will have no idea what that means, but they can kind of understand degrees because that's more usable of a unit for the average person. Next slide, please. So we have some questions here. Maybe the first question we can ask one of the PGY 2s or 3s maybe to try. The question is, how much does a 15 prism diopter prism displace at 3 meters?
45.
45, that's correct. So we know that 15 prism diopters displaces 15 centimeters at 1 meter. So at 3 meters, you multiply by 3. Therefore, you have 45 centimeters. Next question, approximately how many degrees is 30 prism diopters? So this is, again, the patient comes to you with this deviation and they want to know, doctor, what does this mean? How many degrees is this?
Divided by 2, so 15.
That's perfect. So we divide it by 2 and we have 15 degrees approximately, which is correct. Now, the next question, which is another very favorite question on board examinations, is how many prism diopters is 45 degrees? And they want this exactly. They don't want approximately. Not sure why this is relevant in real life, but the OCAP thinks it is.
100.
100. That's correct. And for this one, we actually do use triangles to explain that. So if you look to the right here, we have basically, we know that the definition of a prism diopter is at 100 centimeters, the deviation is 100 centimeters, whatever the deviation is. If we're looking at this angle, which is 45 degrees, And we have this triangle that we've drawn out here. We know by rules of triangles that all angles in a triangle add up to 180 degrees. And because the distance, because it's a 45-degree angle that we're looking for, and then we know that there's a 90-degree angle at the point where the light bends, then the other angle has to be 45 degrees. And by law of isosceles triangles, two sides are the same. So then we know that this must be 100 centimeters. And the last one is the tricky one, and the one that's relevant to our patient, which is how many prism diopters is 90 degrees? So our patient had an ET of 90 degrees. Why didn't we just measure that in prism diopters? And the tricky thing about this one is that the answer is actually infinity prism diopters. And let me explain why. So next slide. We have here a isosceles triangle that again demonstrates that a 45-degree angle is 100 prism diopters. So we're looking for this angle that's subtended 45. And as you go 100 centimeters out, you find that it's 100 centimeters, again, by the rule of isosceles triangles. But if you're trying to subtend this angle to make it to be 90 degrees, which is what the question is asking, how many prism diopters is a 90-degree angle? You're replacing this 45 with a 90. And if you do so, you find that there is no point on the right where that line meets where these lines are essentially parallel. Therefore, it is at infinity. So then we would say here, kind of cheek and tongue, that this is an infinity prism diopter patient. So this is, a concept that has fairly little use outside of, optics and examinations, but it's interesting because it did kind of come up in our case here. And the relevance here is that this patient's deviation was so large that we did not have enough prism diopters to measure this patient's deviation. So really a true, very large angle esotropia, certainly the largest one I've ever seen. Next slide, sorry. One concept, again, just to hit home for the residents, is if you remember nothing else from this optics talk, is that when we have prism diopters and degrees, there is a relationship that's about 2 to 1. That's that horizontal dotted line. And as you move from left to right, you see that that relationship is true. 15 degrees is approximately 30 prism diopters. 30 degrees is approximately 60 prism diopters. 45 degrees we know is exactly 100 prism diopters. But as you move forward to the right, the slope does certainly become exponential. And that's when you reach 90 degrees, you do reach infinity prism diopters. So hopefully that helps you get one question right on your exam. Next slide. But of course, our patient is not an optics problem. Our patient is a real patient with a real problem that we're trying to help fix. This is a severe left head turn. And this gentleman is really interesting for a couple other reasons. He has a NLP vision in the right eye, and he has secondary to ocular trauma. There's multiple RDs. The cornea is very opacified. There's a cataract. There's a shallow chamber. I don't think there will be much help for this eye. But the other eye is 20/20. We know he has bilateral complete cranial nerve 6 palsies. So when this patient is sitting in my chair, I'm trying to figure out what to do with this patient and how to help approach his esotropia. Next slide. The first question that we are going to ask is, which eye should we be operating on? So maybe we pull up the poll question. So would you only operate on the left eye, which is the good eye? Would you operate on the right eye only, which is the bad eye? Or would you operate on both eyes in this situation? So again, right eye, good vision. Right eye, NLP vision, left eye, good vision. What should we do and how can we help him?
So Michael, it looks like most of your audience wants to operate on both eyes.
Operate on both eyes. That seems like the correct answer to me. Next slide, please. So management considerations for one eye versus the other eye. Next, advance the slide, please. The question becomes, should we ever do strabismus surgery on the only seeing eye of a functionally monocular patient, which is this patient? It makes sense on sensory cases that we can operate on the bad eye. Of course, this is very common. We see a patient with a sensory XT, they have one good eye, they have one bad eye. The brain has trouble keeping the bad eye aligned, so that eye tends to drift out. And doing surgery on that exotropic, poor vision eye makes sense. But when should we be doing it on the only good eye of a functionally monocular patient? Next slide. Next, advance, please. And advance again. So some reasons to do so. The first one I would argue for you would be ocular torticollis. So what is that? That is when the patient has a head turn because of their eyes. So we know that this patient is severely adducted. In order for him to fixate, he has to turn his head 40 degrees. This can cause a lot of neck issues and chronic neck pain, which is very bad for our patients. Another reason to do strabismus surgery on the good eye of a monocular patient would be to give surgical access to the eyes. You can imagine that his left eye is fine for now. He has glaucoma. We don't know if it's open angle, closed angle. We don't know if he needs further surgery in the future. He definitely will need cataract surgery sometime in the future. And you can imagine if someone's eye is adducted into their nose, it might be a bit difficult to, do cataract surgery on their eye. If the patient's poor eye had a chance of visual rehabilitation, of course, we also need to move that eye to a central position as well. And the last reason why you might consider doing strabismus surgery on the good eye would be for reconstruction. I don't love the term cosmetic purposes because I don't really think that that's what we should think about strabismus surgery for these reasons, but certainly reconstruction is an appropriate term. This patient wasn't born with their eyes like this, and we're trying to reconstruct their eyes to a more suitable alignment. Next slide. So now we've decided to do both eyes. So we're going to do some kind of surgery. What kind of surgery should we be doing? And again, I recognize that not everyone here does strabismus surgery, but maybe conceptually you can think about or remember back to residency what you would have done. So are we going to just do a bilateral medial rectus recession and lateral resection? Are we going to be doing some superior and inferior rectus transpositions? Should we also, recess the medial and transpose the entire superior and inferior rectus muscle? Should we just recess the medial and maybe just do the muscle belly transposition laterally, also known as a modified Nishida procedure? I think there are many options, and there are certainly a lot that I did not list here as well. But these are just some considerations that people may have when considering to approach this case.
So here we've got a bit of a mix.
So it seems like a lot of people would do the last one, which is the I think what we ended up doing. But just to address some of the other options here, Manlong, could you remove your central box? Thank you. Why not do a lateral rectus resection? So first of all, we have to acknowledge that this angle is very large, and doing just a medial recession and a lateral resection is not going to be enough. And another reason why we know that the lateral rectus recession is not enough is because it's a complete cranial nerve 6 palsy. The lateral rectus has probably not been very innervated for a while now. And if you wanted to confirm that, you can do a force generation test in the clinic, which is where you apply tetracaine to the patient's eye and you grab with a pair of forceps at the limbus and you ask them to maximally abduct their eye. And you're trying to feel if the lateral rectus has any tone to it left. Usually when there are incomplete cases, or even in considerations where, is it a tight medial rectus versus a that's causing a lot of the deviation. By doing force generation testing, you can figure out, is there any, oomph left to this lateral rectus, and would resection of it even do anything? Because if there's no force generation and it is not going to be helpful, then, then doing a resection to strengthen a pretty much dead muscle is not going to be helpful. I see Dr. McAllister has a question about the use of Botox, which is a great question. Certainly, you can consider augmentation of Botox for the medial rectus muscle. I think that's very reasonable, and I would probably do that as well as a recession, as well as a transposition, because I still don't think that just using Botox and recession and a strengthening of the lateral will be enough in this case, but perhaps in less or more incomplete cases, that might be okay. Next slide, please. So what did we end up doing? So we ended up doing that last section D. This is what our op notes look like in strabismus surgery. To summarize for you, we basically recessed the medial rectus muscle in each eye, and then we did what's known as a modified Nishida procedure. I personally don't like using named procedures because it doesn't describe what the technique is. So we did a muscle belly transposition of the superior and inferior rectus muscle to the lateral rectus muscle. So this pictogram on the right side kind of demonstrates kind of the end goal of the surgery. So this is after the medial rectus has been recessed. We are now looking at the eye temporally. So we're looking at the lateral rectus muscle. We see that the superior rectus and inferior rectus, the insertions are still at their original insertions. And we've essentially just sutured the muscle belly laterally. So the inferior rectus, the superior border of, or sorry, the lateral border of the inferior rectus, we've moved it up. And then the temporal side of the superior rectus, we've moved it over to the lateral rectus. This allows the superior rectus and inferior rectus to help aid in abduction. And maybe we'll show a video now of what that looks like. Next slide. And this is the video taken with the case. So this is a fornix-based incision. This is a surgeon's view sitting superiorly. We have now hooked the superior rectus muscle, and now we're ensuring that we've got it all. We don't need to clean up too much of the Tenon's insertions. We certainly did some of that, but now we're just going back along the superior rectus muscle, the lateral aspect, and we're marking about 8 millimeters, which is around where the muscle belly is. Next, we place a double-armed Merceline suture. This is a non-absorbable suture at that 8 millimeter point. And then once we have sutured that part, we then hook the lateral rectus muscle. So remember, we're trying to transpose the superior rectus to the lateral rectus. We then mark about 8 millimeters adjacent to the lateral rectus muscle. We place both arms of the suture through this point, and then we tie the knot down there, which essentially pulls the superior rectus laterally. We would then repeat the procedure inferiorly. This is the inferior rectus muscle. Again, we mark 8 millimeters posterior to the insertion. We then put through a double-armed 5-0 Merceline suture, non-absorbable, hook the lateral rectus muscle, again, mark back about 8 millimeters adjacent to the lateral rectus muscle, and then we then place the Merceline suture double-armed through that part that we marked. We tie down the knot, and then that will then drag over the inferior rectus muscle temporally, so that we're trying to augment the ability of the lateral rectus muscle by using the superior rectus and inferior rectus. Then we close. So as you can see, not too complicated to do. Certainly doable, I think, for a lot of strabismus surgeons in the community, but I understand that maybe some of you don't want to do this. The reason why we decided to do this procedure as opposed to a full superior inferior rectus transposition. So the reason why we did this was that you notice that we did not secure the muscle, we did not detach the muscle, we did not move the muscle over. And the reason for that is we're trying to avoid something that we'll discuss later, which is anterior segment ischemia. That's this concept where if you're operating on too many rectus muscles, especially in an older, perhaps compromised patient from a vascular point of view, then they may risk anterior segment ischemia. Next slide, please. And so this is what our patient looks like 3 months afterwards. You can see he comes back to the clinic and his head is completely straight. He says he doesn't have any more neck pain because he's able to look at you, which is great. His vision in his left eye, importantly, has been preserved. So he's 20/20 still. Pupils are reactive to light. Anterior chamber still looks good. Pressure is normal. Next slide. Really, to look at the before and after, you can really see, oh, sorry, this is the sensory motor exam. So now looking at this 3x3, it looks less like a photo that's been copied and pasted 9 times. You can see centrally that he is in more of a ortho alignment. Certainly, he still measures ET20, but we know from the literature that patients often who are under 20 prism diopters of esotropia, it's difficult for people, like lay people, to be able to tell that there is a deviation, which is why in reconstructive purposes, even getting someone under 20 is a big improvement in their appearance. We don't expect there to be a whole lot of abduction. When someone starts at -6, -7 abduction, it would be incredibly unlikely for them to have really any improvements in their abduction. He has a little bit in the right eye, but the left eye you can see really does not abduct past midline, and this is entirely expected. It would be very unusual to accomplish more than this. This is already what we would consider a very excellent result. Next slide, please.
Mike, can I just make a comment?
Yes, please, Dr. Smith.
Yeah, so it's Dave Smith. Actually, the procedure you did is not a modified procedure. The original modified procedure is actually an anatomy procedure, which was they split the muscle and bring it down. This is an actual, this is the actual procedure that was described by Nishida, and it wasn't modified. And in North America, we've mixed up these references. There's a couple of good papers about this. So in 2003, Inatomi actually did what you were describing, and then Nishida, about a year or two later, actually did what is it, the muscle procedure without splitting the muscles at all. So that's the original Nishida procedure.
Thanks, Dr. Smith. And this again reiterates my point about why I really dislike using named procedures to describe techniques when I just like to describe, this is a lateral muscle belly transposition, much easier and much, more descriptive of a terminology. So thank you for correcting that.
Perfect. Yeah, that's it.
So this before and after again just shows the head turn, very severe 40-degree head turn into a much more reasonable 5-degree head turn. And you can see that we have treated this patient's infinite prism diopters to a much more reasonable 20 prism diopters. The title of this case was, from eye cross to star-crossed lovers, trying to get these cross eyes to be as far away from each other as possible. Next slide.
Okay, so how about the anterior segment ischemia? As we know, so operating on multiple muscles at the same time is a risk factor for anterior segment ischemia. Luckily, our patient had a great outcome with no ASI. And in order to reduce the complication of surgery and including ASI, the modified Nishida procedure was introduced in 2005 by Nishida and his colleagues. This procedure does not involve any tenotomy or muscle splitting. Therefore, it reduced the risk of surgical complications, including ASI. Here are some studies and case report series showing the outcome of modified Nishida procedure in with and without some adjunctive procedures in correcting esotropia. As we can see, the vast majority of the patients had a great outcome with very good esotropia correction with no anterior segment ischemia. The only report that I can find is one case report of ASI following modified Nishida procedure by Melodina and colleagues that was published in 2023. This was a 68-year-old female with a history of hypertension and diabetes. She underwent modified Nishida procedure for her esotropia, and on post-op day 1, she was found to have decreased vision and eye pain, and ASI was diagnosed. And the patient was brought back to the OR on the same day, and the procedure was reversed. The patient had a very good rapid recovery of the vision and the ASI, and her vision was back to her baseline in post-op 1 month. By the way, the patient, so before the modified Nishida procedure, the patient did had Botox injection into both medial rectus 4 months prior to that operation. So what exactly is anterior segment ischemia? It occurs when the blood supply to the anterior segment through the ciliary and arteries within the 4 rectus muscles is interrupted. It frequently occurs with vertical rectus transposition. For OCAP, as we know, there are 2 anterior ciliary arteries on each of the 4 rectus muscles, except for the lateral rectus, which only has 1. The incidence of anterior segment ischemia is quite rare. It's about 1 over 13,000 cases. but when it occurs, it can be serious potentially. The risk factors for ASIs are operating on multiple muscles on the same eye at the same time, previous strabismus surgery, adult patients. The older the patient, the higher risk of having ASI. Also, some microvascular disease such as hypertension, diabetes, and dyslipidemia are all risk factors. Also, compromised long posterior ciliary circulations, such as patients following retinal detachment surgery with scleral barcode. Finally, limbo-conjunctival incisions may be another risk factor as well. So based on those risk factors, the primary prevention of ASI include try to limit the numbers of muscles operated in each eye at the same time. So the general guideline is to avoid working on 3 or 4 rectus muscles at the same time. Also, we can consider Botox injection instead of the traditional strabismus surgery. Additionally, consider some special surgical techniques such as vessel-sparing technique, plication, and partial tenotomies. Finally, try to stage surgeries and have at least a couple months between procedures that may help. And finally, try to use fornix conjunctival incisions instead of a limbo incision, which may also help. The finding of ASI would include slow or asymmetric pupillary light reaction, iritis such as AC cells and flare, corneal edema, and DM films. Here is a photo of ASI following superior rectus and lateral rectus surgeries in a patient with history of scleral buckling. As we can see, so their corneal edema with an irregular pupil, and this is so there's some atrophy of the superior temporal iris. When this is severe, ASI can cause anterior segment necrosis and phthisis bulbi, as we see in this patient here. This is another example of ASI. It is a 40-year-old man 2 weeks after vertical rectus transposition to the lateral rectus for his cranial nerve 6 palsy. The patient had previous medial rectus resection 20 years ago. As we can see on the photos in the left, there's an irregular pupil with inferior temporal iris atrophy. The image on the right is a fluorescence angiogram showing the delayed vascular fillings of the iris in the temporal and inferior quadrants. In terms of management, there's no universally agreed upon treatment for ASI. Typically, topical, subconjunctival, or systemic steroids can be used to reduce inflammation until collateral vascularization occurs. However, there's no firm evidence supporting this approach. And as we know, when it's severe, ASI can lead to necrosis and phthisis bulbi, but likely most cases resolve over time. Now, let's move on to look at the impact of strabismus on psychosocial equity. As we know, strabismus can result in severe, long-lasting functional and psychosocial sequelae. In one study on strabismic patients aged from 15 to 25 years, patients reported they avoid public speaking and answering questions in classes. More than half of patients report that their strabismus changed their career ambitions or future plans. In another study, social phobia rates in adults with strabismus were significantly greater at 53% compared to the normal controls, which are at 17%. In the same study, looking at the strabismic patients after surgery, 97.5% patients reported a positive change in appearance, and 95% endorsed a positive change in relations and self-confidence. Also, 62% no longer felt the need to change their future career plans because of their strabismus. All these findings highlight the profound psychosocial impact of strabismus surgery. So here are the key learning points. First, the indications for operating on the good eye of monocular patients are ocular torticollis, future surgical access to the eyes, and reconstruction. For OCAP questions, for angles less than 100 prism diopters, 1 degree is equal to about 2 prism diopters. Also, anterior segment ischemia is a serious complication that should be considered when operating on 3 or more rectus muscles. Finally, the psychosocial impact of strabismus and successful strabismus surgery is profound and should not be minimized. Here are our references. Thank you so much for listening.
Thank you, Manlong and Michael. I think that was a wonderful case. Really well managed, Michael. I was very, very impressive. And maybe we'll get your slides up. But, you know, the last part, the social impact on that patient is going to be immense, right? Just the way others perceive him. So well done.
Thank you. Anna, would you like to unmute yourself?
Yes, thank you. Okay. Hello, everybody. My name is Anna. I'm a PGY3 resident. Today, I'll be presenting a acute case of esotropia. Thank you, Dr. Nguyen, for the opportunity to present and for guiding us in preparing these presentations. So the objectives today are to review the approach to acute acquired comitant esotropia, to review the evidence for botulinum toxin in strabismus. And here's our case. He's a 5-year-old boy who woke up 2 weeks ago with crossed eyes. He's otherwise systemically well with no past medical history and no past ocular history. We have a poll question for the audience. Which 2 exam maneuvers are the most important to perform in this case to rule out neurological involvement? Is it visual acuity, dilated fundus exam, cycloplegic refraction, deviation measurements, or extraocular motility?
We'll let it run. I'm not sure if we allow 2 selections in the poll, and I can't do it myself right now.
I think we do. I think I
We
asked
do,
for it.
okay.
Yeah, so I think people should be able to click 2 things that they would do.
Okay, perfect.
Or the most important thing, sorry. You would do all these things, of course, but the most important thing.
All right. I'll share the results here.
Perfect. So as most of the audience got it, so the most important things are dilated fundus exam to rule out papilledema and extraocular motility to rule out cranial nerve palsies. Here are the exam findings for our patient. His visual acuity was 20/20 in each eye. There was no optic disc edema. Cycloplegic refraction was plus 1.25 sphere in both eyes. The deviation was a comitant esotropia of 45 prism diopters at distance and 45 prism diopters at near. And there was no limitation of abduction in both eyes. So there was no neurological involvement in this case. This is a case of acute acquired comitant esotropia. It's characterized by a sudden onset eye misalignment with an equal angle of deviation in all fields of gaze. The mean age of onset is 4 years. And this is distinct from other forms of esotropia, such as infantile, accommodative, restrictive, and paretic. How is acute acquired comitant esotropia diagnosed? As the name suggests, the onset of signs and symptoms is acute and clear. So there's a very clear point in time when the eyes suddenly became crossed. It's acquired, so not intermittent or decompensated. It's comitant, so there's an equal angle of deviation in all eyes, in all fields of gaze. And it's an esotropia with a median deviation of 35 prism diopters. Do we need to do neuroimaging for acute acquired comitant esotropia? According to one paper, by Bush and Vindig, there are 4 risk factors for intracranial disease. One of them is larger esotropia at distance than near, a recurrence of acute acquired comitant esotropia, so anytime that it seems to have resolved and then comes back, presence of neurological signs such as papilledema, and older age of onset of more than 6 years. So these risk factors would prompt neuroimaging. How is acute acquired comitant esotropia treated? So there are different options. Observation is not recommended for these cases because they rarely resolve on their own. Prisms are also not recommended because for a deviation of more than 10 prism diopters, the prism would just induce a blur. So the 2 options are strabismus surgery and Botox injections.
I'm just going to jump in here with this video that demonstrates a Botox injection. So if you pause the video for a second.
Sorry.
Yeah, and just go back. I just want the setup where this patient is. So this patient is, as you can tell in the top right, they're currently being bagged, masked. So they're not under general anesthesia. They're not with an LMA. They're in a sedation unit, and there's probably some ketamine on board, and then there's a mask, and then the anesthesiologist is just providing bag mask breathing, and you're able to do this procedure very efficiently and quickly. We put in tetracaine, we put in betadine, and there is a lid speculum in the eye. So that's the entire setup. We have obviously the Botox reconstituted and ready to go. And if you can start the video now, it's a very simple procedure. We do not use EMG guidance. We basically grasp the limbus. We bring the eye out to an abducted position. We then use a pair of Bishop's forceps or some kind of thick grasping forceps, and we just directly grasp the medial rectus muscle. And then transconjunctivally, without any dissection down, we inject the Botox into the belly of the medial rectus muscle. We inject the Botox, and then we withdraw. And that is literally it. That's the entire procedure.
So in relation to this case, we're going to discuss a paper called 3-Year Outcomes of Botulinum Toxin versus Strabismus Surgery for the Treatment of Acute Acquired Comitant Esotropia in Children. It was recently published in the American Journal of Ophthalmology. This study involved 76 pediatric patients aged 2 to 10 years with acute acquired comitant esotropia with over 3 years of follow-up at Boston Children's Hospital and the Hospital for Sick Children in Toronto. There were 44 patients treated with botulinum toxin and 32 patients treated with strabismus surgery. The aim of the study was to determine whether Botox was as effective as strabismus surgery for treatment of acute acquired comitant esotropia after 36 months of follow-up. The primary outcome was success rate at 36 months, and this was defined based on strict criteria from the Cochrane Library. These criteria are deviation of less than or equal to 10 prism diopters, binocular single vision, and no need for retreatment. Secondary outcomes were angle of deviation and stereoacuity, duration of anesthesia and time in PACU, and the rate of complications. Here's a table 1 with the baseline characteristics for the 2 groups. As you could see, the median age of onset, the sex ratio, and the median deviation were not statistically significantly different between the Botox and surgery groups. The median onset of symptoms to treatment was significantly lower in the Botox group compared to the surgery group. There are a few reasons why this may have been the case. One of them is that Botox is a much shorter procedure, so it might be a lot easier to find OR time for Botox injections compared to surgery. The other reason is that many surgeons prefer to follow their patients for at least several months before doing surgery, and this is to ensure that the measurements are stable. And this is not necessarily required for Botox. In terms of treatment, the Botox group had a median pre-op deviation of 35 prism diopters. 36 out of 44 patients received 5 units of Botox. In the surgery group, the median pre-op deviation was 35 prism diopters, and the median amount of recession was 5 millimeters. This is a chart showing a comparison of the mean surgical time, duration of anesthesia, and time in PACU. So For the Botox group, the surgery time was 5 minutes, whereas in the surgery group, the surgery time was 61 minutes. Anesthesia time for the Botox group was 9 minutes, and in the surgery group, 71 minutes. And PACU time in the Botox group was 40 minutes, and in the surgery group, 95 minutes. So this is equivalent to 90% less surgery time, 90% less anesthesia time, and 60% less PACU time for the Botox patients compared to the surgery patients. There were some complications that were specific to Botox injections. One of them was transient ptosis. This occurred in 45% of the patients. And the median time to resolve was 6 weeks, and this is according to parental report. Another complication was transient exotropia. This occurred in 48% of patients, and the median time to resolve was 5 weeks, again, according to parental report. There were no serious or lasting complications in either group. So now we're coming to the outcomes. So the primary outcome was success rate at 36 months. The success rate was 72% for Botox patients and 56% for surgery patients. And the p-value was 0.24. The median deviation and median stereoacuity was not statistically significantly different. And as you could see, the success rate was also not statistically significantly different between the two groups. So the next step in this study, once it was established that the Botox group did not differ from the surgery group in a statistically significant way in terms of success rate, the next part was to perform a non-inferiority analysis. So the question here is, can it be concluded that Botox is non-inferior to strabismus surgery? So here's an axis. As we move to the right, we're saying that Botox is better than surgery. And as we move to the left, we're saying that surgery is better than Botox. In order to do a non-inferiority analysis, a margin needs to be determined before the study has begun. And this is based on previous literature. And basically this non-inferiority margin was set as minus 10%. So we're saying that if surgery is 10% better than Botox or anything on the right of this line, then we're concluding that Botox is non-inferior to surgery. What was the actual success rate? It was 72% in the Botox group, minus 56% in the surgery group. That's plus 16%. So we're lying on the right of this line. And then a 95% confidence interval was calculated, and it was found to be minus 5% to 38%. So at worst, Botox is 5% worse than surgery, and at best, it is 38% better. As you could see, this confidence interval overlaps the 0% line, which explains why the groups did not have a statistically significant difference in the success rate, but it does not overlap the 10%, minus 10% non-inferiority margin, which means that we can conclude that Botox is non-inferior to strabismus surgery. There were some limitations in this study. First, it was a retrospective design, so there could be inherent selection bias. The time of onset to treatment was shorter in the Botox group compared to the surgery group. And acute acquired comitant esotropia is an uncommon condition. Only 1.3% of all surgically treated strabismus at our 2 centers. So it was hard to get a much larger sample size than this. Back to our case, this patient was added on to the next day's OR schedule, received 5 units of Botox to each medial rectus muscle. 5 days later, the eyes appeared straight, and 6 months later, the eyes were still straight. Key learning points are that acute acquired comitant esotropia is a distinct entity with different management compared to other forms of esotropia. Always rule out neurological involvement. And Botox is an effective alternative to strabismus surgery for the treatment of acute acquired comitant esotropia with excellent long-term outcomes.
That's great. Thanks, Anna. If you just stay on the slide. Something that I just wanted to, again, highlight is that when we think about esotropia, not every esotropia is the same. As I've demonstrated, here, there are 6 nerve palsies. There are, even for children, we have infantile esotropia, we have accommodative esotropia. There's many different types, and ACE is just another distinct entity. And it's important to be able to come up with this diagnosis, which is honestly mainly through history. It's important to get the history of that sudden onset. You know, my child was completely straight, and then the next day their eyes were completely crossed. That is the history you want to be able to elicit. And the reason why you want to elicit that, one, is that you want to rule out neurological involvement, because that could also very well be a cranial nerve 6 palsy. And the second reason to get that history is that, you know, ACE and Botox is a topic that's very, you know, near and dear to my heart, because I think that there's been a lot of interest in the use of Botox for strabismus for a very long time, for at least, you know, 40 years, which is when Alan Scott came up with the concepts and started doing it for strabismus. But unfortunately, we think that in the literature, a lot of the success for Botox has not really panned out in other forms of esotropia. Where it has shown the most promise is in this specific entity of esotropia. And one more point I wanted to highlight about that study that we did was that it was 3-year outcomes, which for strabismus surgery is quite long for outcomes. And it's interesting, especially for Botox. You know, we think of Botox, at least in this day, from a cosmetic point of view, we think about patients who come in and get Botox, you know, every few months. And the question that's asked is, you know, do these patients need to get repeat injections of Botox to treat their acute acquired comitant esotropia? And the answer was actually, you know, no. The patients don't really need to get repeat injections. And, you know, the reason for that long-lasting effect is still unclear, but we think that that has to do with, you know, perhaps microscopic anatomical changes at the neuromuscular junction. Perhaps there's some stretching of the paralyzed muscle and then contraction of the antagonist muscle. But I think more importantly, in this case, it's that reestablishment of binocularity. So these patients typically have had normal binocular development as, you know, a 1 to 3-year-old. Then they develop this ACE at age 4. And then if you're able to quickly, and that's a very important point, quickly reestablish that binocularity, then their own already developed system of binocularity will be able to kick into effect and allow them to keep their eyes straight. So that's why I think that in ACE, Botox has the highest potential for use. So it's important to get this diagnosis, because if you miss this diagnosis and you know, have this patient wait for weeks and perhaps months, perhaps years until their surgery, then perhaps the outcomes would not be as good as they could be with quick management. So this patient presented 2 weeks ago, and then we did the botulinum toxin, and they're able, at least at the time of the end of my fellowship, 6 months later, eyes are still straight.
Excellent. Michael, we've got a comment from Dr. Smith. We'll go to him next.
Oh, I just wanted to make a comment. I saw a couple of patients and sick kids come in over the years. They were at school, they're in kindergarten, all of a sudden they went esotropic and they came into sick kids emerge in their wheelchair and they were going to have a big neuro workup. But they came to the eye clinic and the resident or the neurology people didn't want to have cyclo put in. But I had cyclo put in. I looked at the mother. The mother was a +5 and the kid was a +6. And as the cycloplegia was working, the eyes started to straighten out. And so I'm just really suggesting that some of these are accommodative and you have to be absolutely certain. So the question would be, if you had a sudden onset esotropia and it was a +450, or when would you give glasses? You see, what I'm trying to suggest here is there's a spectrum. And I think you have to be careful that you're not just dealing with something which is non-accommodative just because your first refraction might have been poor or not completely bringing out the full accommodation. So my suggestion would be, and maybe you did this, I would maybe want to have a couple of repeat cycloplegics to make sure you're not missing some cycloplegic accommodative mechanism. That's all. Because this kid, his brain tumor went away with the glasses, and the mother was really happy that didn't require any surgery.
Yeah, that's a really important point, Dr. Smith. Very important. That's why we always tell the residents to make sure we get a good cycloplegic refraction in every patient who comes to sick kids.
So Michael, with these cases, in the acute presentation, you know, what would be the indication for surgery? It sounds like, you know, Botox is a much better first-line option.
I mean, I agree. I mean, a big barrier can be the parents, because when you bring up the term Botox, parents for some reason get very you know, concerned because they associate it with the cosmetic. They think about need for repeat injections. So that's one barrier that I found for its acceptance by parents. I think for indications for surgery, I mean, in these cases, I tend to consider using Botox first anyways. You know, the side effects or the complication risk is quite low, other than the transient ptosis and transient exotropia, which you need to kind of counsel parents and walk them through that period of time, because you know, you do these Botox injections and sometimes their kid comes out with like a droopy eyelid, their eyes are like out, and they're like, oh my God, what kind of eye doctor did I send my kid to? So that period of time for up to, you know, a month after that this study showed involves a lot of kind of, you know, comforting the parent and reassuring them. But in general, I would try that first, because it really, even with Botox afterwards, it doesn't really change the surgical approach. Like, let's say Botox doesn't work. That's okay. We can still do surgery afterwards. I don't think you're missing out on much by doing the Botox first, because as we showed, most people, most surgeons who do surgery, they tend to have waited. Like in our study, the median time to surgery from onset of symptoms was 7 months. So that's still a very long time for those patients.
Great, thank you. Dr. Wan has a comment or question. Let me just get to him. Go ahead, Mike.
Oh, thanks, Omni. The other reason I'd say is that the evidence up to now hasn't been very good for Botox. I mean, Mike's pretty humble about it, but his paper really is the first to show that the long-term outcomes of Botox are basically as good as surgery.
All right, well, thank you. Mike is too humble, and that's why he's my Valentine's Day. He's my Valentine's today. So thank you guys. Great cases, Michael. Excellent. Manlong and Anna, that was great. And I got to say, those videos were awesome. It really does add quite a bit. So excellent to see the videos in pediatric ophthalmology as well. Thank you everyone for joining today. The eval link is there, and next week we have Dr. Clara Chan presenting for our grand rounds. I'll see you guys there.
Thank you.
Thank you, everyone.
Link.
Oh, I didn't do it.
Let me send it to you.
Please, thank